afternoon and welcome to June's ePrescribing Masterclass. For those of you that I've not met, I'm Amna Patel, Clinical Fellow at NHS England and a pharmacist by background. It's great to see so many of you here to join us for our special masterclass with Emma Kirk and the hospital organisations that will be sharing their learnings around medicine safety. So just in terms of the masterclass themselves, they're a platform for organisations to share their learnings around medicines optimisation of EPMA systems, as well as innovative research and practice around digital innovation. So I will pass over to Emma, and Emma is the Medicine Safety Officer Network Lead. Emma, over to you.
Hi, thanks very much, Amna. And I think Amna and I were chatting earlier. This is the 4th joint session that we've done, so aiming to do them annually. And you know, it really is great. We set up these joint sessions in recognition of the important relationship that's needed between clinical informatics and safety. And over the years, it's been great to hear all about the work that's been undertaken together, primarily to support medication use in our patients. Just want to take this opportunity quickly to ask attendees that if they have any experience of using smart pumps with drug error reduction software, please could you complete a survey. The QR code is there. This has been set up by the Medusa Smart Pump Working Group, and they've been working on creating a standardised nationwide drug library for smart pump infusion systems. The aim of the survey is to collect data on the current utilisation of smart pumps and their integration into electronic prescribing and administration systems. So if you do have experience of that within your organisation, please do complete the survey. So we've got some great speakers today. I've had the pleasure of working directly with our next speakers at my previous organisation, and I'm really grateful for the support they gave me as an MSO and the way we were able to work together on numerous projects to support safety. They're going to be chatting today about cyber attack and downtime. I'm sure that you will all have processes in place to manage downtime. Hopefully it's planned and expected. If you don't, hopefully this presentation will illustrate the importance of having those in place, and you might want to go back and have a think about it. I was at the organisation when this happened. It was really stressful, particularly for the brand new to post CCIO. But I have to say the team made it look totally under control and calm. So I'm going to hand you over now to Brian and Layla to share some more about how they managed the situation. Thanks, Brian.
Thanks, Emma. Okay, thanks for the opportunity to present. It's about our cyber attack in late last year, and particularly about the implications for EPMA and the lessons we learned on the back of it. So I'm going to present the first part of the presentation, and my colleague Layla will pick up the second half. And we just want to acknowledge the contribution and leadership of Sandra Oliver, our CCIO for Medicines and Pharmacy, who basically coordinated the pharmacy response during and after the downtime process. So for the presentation today, I'm not going to focus on the technical details of the cyber attack, but rather on its impact on EPMA and the lessons that we learned on the back of it. So broken down, I'm going to talk about the timeline of the event, what we did on the night of the downtime, and the unprecedented 8-day coping with a prolonged downtime and lessons learned. And Layla will then talk about planning for recovery, recovering, and what happened post-recovery. So the actual timeline was basically Monday, the 25th of November. In the late afternoon and evening, there was some unexpected network activity detected, which led to system downtime being declared and a major incident being declared by the Trust. It didn't just affect our EPR system, which is Oracle Cerner, but also affected other systems used within the Trust. For us, it affected PowerGate, which is involved in transmitting orders to wholesalers. Thankfully, the stock control system stayed up, as did our Omnicell cabinets, but some of the backup servers associated with these were also affected and needed to be rebuilt. As you can see from the timeline, it was prolonged. All of us have business continuity plans in place, which usually expect to be down for shorter periods of time. None of us usually plan for it being down for 8 days. Obviously, subsequent to coming back on the 3rd of December, we've had both departmental and trust debriefs to reflect on the downtime, what we learned, and what lessons can we take from that for the future. As we know, cyber attacks are more common these days, not just in healthcare, but across businesses in general. And they can bring great destruction and have a massive impact on the way we work. One only has to look in, outside of healthcare. We've had our, big organisation like M&S take a big hit the last month due to cyber attack. The other thing, it becomes national or local and national news very quickly, which adds to the complexity of dealing with the situation. Not only do you have to manage it, but the comms that go out have to be good and on point to try and prevent any, misinformation and local panic. So getting back to our actual night of downtime. So basically the evening of Monday, 25th of November, as I said, there was some unexpected activity picked up in the network that the digital healthcare team investigated. And as it became clear into the late afternoon, early evening, that it looked like it was significant and could potentially have an impact on our clinical systems, the trust moved to declaring a downtime. But in the hours before that, they communicated to the various departments and clinical areas that downtime was pending. So it gave departments time to actually plan. And while we have plans both for unplanned and planned downtime, we were actually able to utilize a bit of both in our response to this initially. So one of the first things we did was actually print out drug charts, so drug administration and prescribing could continue during a downtime process. And we had a choice between what we call 724 drug charts and a Wirral Millennium Medicines transfer report. We went with the transfer report. This is something you can only generate when the system is still up, and it has the advantage that you can have 5 days of meds administration tasks on this, and the prescription information is presented more clearly for clinical staff to follow. So the pharmacy team who were on, many who stayed late that evening, coordinated printing out these drug charts across the trust in the majority of areas, not quite all. Then there was trying to facilitate access to the 724 downtime system, which basically consists of a computer on each ward attached to a printer that's used, that information is backed up on a regular basis and that it's used in a downtime situation. But the lessons we learned, obviously communication in the early part of downtime is very difficult. It's a fluid situation, but the comms was pretty good and it allowed departments at least to get a few hours notice before we went down. But we found different clinical areas and departments, some were very unfamiliar with processes and packs because it was over 4 years since we had a significant downtime before. And we'd issues with the 724 system. Some machines were not set up correctly. Some places struggled to get the access codes. And in some, the printers weren't working. So there were several learning points, especially for our digital healthcare colleagues to take away. But the biggest learning point for us the biggest issue was the prolonged nature of this. We didn't know when it first went down that we're going to be down for 8 days, and this would include a weekend. And it brought unprecedented challenges that we didn't necessarily have to deal with before, including the management of resources and trying to make sure people got rest and weren't in all the time and just actually driving themselves into the ground. Communication was a big thing, and working with our medication safety colleagues, among others. And we communicated to the pharmacy team regularly and often. We had twice daily team briefings. We each day regularly assessed issues because every day brought a different picture. We didn't know when we were going to get back. So the drug charts that we had printed out, after 3 to 5 days, they started running out, and we had to make a decision on when we transcribed to full paper charts, which we were already using for new patients. And obviously some staff were unfamiliar with these. Some staff just, we've 3 decades of EPMA experience in the trust, so that a lot of staff were not used to handling paper charts. And we had logistical difficulties, such as just getting our hands on enough paper charts and other downtime paperwork because of the unprecedented scale of the problem. So among the lessons learned here were, again, comms, comms, comms. And within the department, I think across the various teams, it's something that we did very well with support from a lot of senior leaders within pharmacy. We felt there could have been better central comms across the trust. Sometimes the central command, the communications down to departments was suboptimal and made some planning difficult. We also learned it was fine having verbal meetings, but we needed to supplement better with written comms. As we said, a lot of staff were unfamiliar with certain processes or even paper charts. So we developed a series of action cards. We also found we needed to adapt and be pragmatic during the prolonged downtime. You couldn't deliver the normal standard of service, and trying to deliver clinical pharmacy services in a prolonged downtime was a challenge that we had to adapt to and come up with some solutions to. And as well as that, we forgot to communicate to community pharmacies that they wouldn't be get farm outcomes referrals. So again, that's something that will be higher on our agenda in the future. But one of the key things was to start planning early for recovery and how to manage that. And Leila will talk you through the recovery process.
Thanks, Brian. Okay, so as Brian said, we're going to we started planning really early for recovery, and we had many different versions. We needed to consider how many staff we'd have. We didn't know what day it was going to happen. We needed to plan for a range of scenarios. But the main thing was, because we were down for so long, we basically had to treat it like a new go live. There wasn't so much recovery as it was just starting again from scratch. But fortunately, we've got a lot of experience in our trust, both with go lives and also planned and unplanned downtime. So this came into effect. At the point of doing this, we still also had ongoing scrutiny in the media, and we also had opportunistic phishing from people trying to get organisations trying to get more information out of the staff at a time when they would have been distracted and sort of not taking the usual care that they would normally to make sure that the information stayed safe. This is just an example of the kind of planning spreadsheets that we had for our wards. So the things that we need to think about was the acuity of the ward, how many beds we had. You can see at the bottom there's tabs, I don't know if you can see, but we've got a different tab for each scenario of how many prescribers we had volunteering. So sometimes our plans were for had to have as little as 10 people turn up, and then up to over 40 turn up. In the end, we had over 100 on the day. So the downtime recovery, we communicated as much as we could to everyone. We utilised teams of prescribers and checkers, and we gave everyone a clipboard pack that had all the information in that they needed and information that they could refer back to. We sent teams of people to wards in a controlled manner, and they just swept from one end of the hospital to the other. We also had a roving team to cover any transfers. This took all day, as you can imagine. So we had teams that would pick up any stragglers of patients that got transferred during the day. We also used our MMTs, our meds management technicians, to pick up any supplementary tasks that could be done, use them to coordinate and sort of help support the teams. We also had a leader for each group of teams, so that they had someone on site that they could quickly refer back to. And then there was a command centre and pharmacy that we used to sort of direct everyone. Okay, so the lessons learned from the downtime recovery, basically the accuracy of getting your patients in the right bed is absolutely key. The admission, transfer and discharge process did not go smoothly at all. And we had lots of time wasted where teams turned up on the ward to do the transcription, and half the patients still weren't on the system because of various miscommunications and mix-ups, and staff that had gone home and not handed over centrally. We were quite clear on what we needed to do from a transcription process for medicines, but for prescribing. But there was also, because we've been down for so long, there was lots of other tasks like last dose administered that we made a decision to document, and in hindsight that did not go very well. We didn't really understand the implications of what we were planning to do, and it really slowed us down because it was quite time consuming, and there was a lot of miscommunication about what that instruction actually meant. We also had problems with just managing the vast number of people. As I said, we had over 100 people doing the transcription process, and no matter how hard you try, you're never going to be able to control that many people. So it was kind of a case of just do what you can. We had people who could only do certain hours, had to leave early. Some of the doctors only wanted to do their areas and not move on to unfamiliar territory. So it was a case of just trying to manage that as well. Okay, once we'd got over that very long day of post-recovery, we made sure to take a breath, take stock, made sure that all our outstanding issues were documented, reviewed. We'd had a lessons learned spreadsheet available to all staff to fill in anonymously or in person, and that was open during the whole of downtime. And we basically gave staff a couple of days to try and get all that information down once we'd managed to take stock and think about it before we moved on to other things. Post-recovery actions in the days following the actual downtime recovery, whenever we were back electronic again, we contributed to the debriefs that went on in the trust. We also straight away replenished all the downtime packs on the wards, which was quite depressing, but you do need to be ready for anything. We could have gone into another unplanned downtime for any reason, and we'd completely destroyed all the stock of everything we had. So one of the other things we needed to do was agree downtime prescription charts and other documents that we could replicate quickly when needed. We reviewed every single feedback suggestion that we got, and we categorised it, and then we assigned it to a lead to take forward. Anything that wasn't within pharmacy's remit to deliver was escalated to the various teams in the trust. Okay, so the next steps in the weeks and months, because it's kind of, it takes a long time to recover really, is that we looked at doing some education and training videos. So as Brian said before, we had staff who didn't know how to use a drug chart, didn't know how to interpret them. So we agreed that some educational videos would be really useful for staff to do that. Our clinical services are looking at how to support staff especially during a prolonged downtime. It's kind of a misconception that you can just get away with doing the bare basics or a weekend service. Once you're down for that long, you need to start providing all the care to your patients. And also staff didn't know where to get information from because they weren't sure where it was being documented, where they would normally look on the electronic system. We did an end-to-end process review, so looking at action cards, making sure that we could get our hands on things quickly. And then just to round it off, obviously, as Brian said at the very top, we had other areas that were of concern. So we looked at business continuity plans for things like JAC and Omnicell and Powergate that had also been affected during the downtime. And I think that is us ready for questions.
Thanks, Layla. I can just see one question, which I think you did answer right at the beginning, but I'll just pose it to you. So Kathy has asked, where did you get the up-to-date information from to transcribe all the meds onto the paper charts? So that was your transfer list, isn't it? You use Cerner to print off.
Yeah, so we use Cerner to print off a meds transfer list. And then you can also use, if you don't have that once the system's gone down, we've also got a backup, which is our downtime software, which is 724.
Now there's two questions in the Q&A as well. So the first one was about catching up with drug administrations. Thanks, Matt from Tees. So basically, this is always a contentious subject in any downtime, but particularly with a prolonged downtime, I would say it's impossible to catch up on your drug admin record. We, when we were doing the recovery process, aimed to just capture the last dose administered, and that is something we don't think we do again. It would create too much difficulty. It slowed down the recovery effort. So in previous downtimes, we have just basically, said when you get back up, you have to refer to the paper charts for a process. And the other question you asked, Matt, was around simulations. And again, that's a really interesting area. In theory, it's a really good idea if we could run a downtime simulation maybe once a year across the trust. In practice, it's really hard to deliver. We find that after a downtime, the trust moves on very quickly in terms of its priorities. That's why we were really keen this time to try and capture our lessons learned really quickly and update our action cards and review our processes within pharmacy. But getting the trust to commit to such a big undertaking is a challenge, even if it would be worthwhile.
Thank you for answering those two questions.
Thanks, Brian. One thing I've got to add is don't expect staff to just read the action cards. Layla said that everyone went out with their clipboards, but then no one read them and everyone started just prescribing things as they thought they would. So I think, actually go through, read them with them. And then just for the MSO colleagues on the call, one of the things that as an MSO I found really difficult were that lots of decisions needed to be made really quickly, and then we didn't have the time to consider all of the unintended consequences and ways to mitigate them, which I think as an MSO, that's what you spend your life doing. And the decisions needed to be pragmatic. And often you were actually looking at the least worst option. And so that was quite challenging to think in that way as an MSO, when I think possibly we're not always used to doing that. And also, once you're on paper, those errors that you've got used to not seeing anymore, like U for units, suddenly come back. So actually, when you're trying to talk to colleagues about the safety net that they're providing, it's a different type of safety net, because a lot of your junior staff have never had to pick up that U before and that type of thing. So it was, I think the way that we were working clinically changed as well. Thank you so much, Brian and Layla, for sharing that with us. I think it was really useful and has given people lots of things to think about. So moving on from colleagues that I did work with to colleagues that I now have the pleasure of working with or starting to work with, our next session is going to show a number of digital innovations, starting with the importance of the team, and then using your system for reporting, and then onto a specific safety concern, which they've developed an electronic solution. So I'm going to hand over to Sarah, Ben and Leah, who are joining us from University Hospitals of Liverpool Group. Thanks a lot, Sarah.
Hello, thank you, Emma. I'll ask my colleagues to introduce themselves as they take over the presentation. But for introduction, my name's Sarah Thompson. I am CCIO across our University Hospitals Liverpool Group, and I think the first thing I want to do is, I guess, explain a little bit about the organisations that we're talking about. So our team, our digital medicines team, provides systems and support across Liverpool University Hospitals, which consists of Royal, Broad Green and Aintree, and we also provide service to the Walton Centre NHS Foundation Trust. Now, just to complicate matters, we are in a group model. We're also in a group with Liverpool Women's Hospital, and they have their own digital medicines team using their Meditech EPR. So the work we're talking about today is very specifically around our digital medicine systems for our Luft and Walton Centre colleagues. Yeah, it was just to, I guess, outline the landscape we're talking about. So the work that I'm going to introduce to you is a piece of work that might look familiar to my Wirral colleagues from my former post. It's a piece of work we've done to try and outline why we are not an EPMA team and why we are the digital medicines team for the organisation. and a piece of work we've done to try and explain the breadth and complexity of the systems and services that we're supporting. So I'll take you through our little journey, and hopefully you'll see where it's coming to in our universe at the end. But we were trying to outline the question of why do we need a digital medicines team? Why is it that, you know, we are in need? So we have a core team of pharmacists, pharmacy technicians, we've got a business analyst, we've got admin support, and we provide troubleshooting for the systems. We provide system configuration, system support, and we also manage our devices within pharmacy. So that's, I guess, the core offering that our team bring. And when everybody asks us about our systems, the core one it comes to is ePMA, which across our organisations we use WellSky. We upgraded to Careflow last week. So we are a WellSky trust, and that covers our ePMA, our stock control, dispensing, and our aseptic services. So that's, I guess, from the outside looking in, what everybody thinks our team manages. Now, actually, to be able to manage that system, there's a whole wealth of information and resources and other systems that we have to be aware of and help configure. So I'll not run through them all in sort of succession, but really when we're talking about managing our pharmacy stock control in ePMA, there's a whole host of integrated systems, interfaces, reporting, external data provision, and things like stock ordering that we absolutely have to have a handle on, and some of these we do directly manage within our team as well. We've got fundamental pieces of technology that keep our department running, our VBACS robots across Aintree and Royal, and, you know, very close to heart from the previous presentation, we manage our business continuity solution and plans as well, our disaster recovery and business continuity. We are also in a position now, as of yesterday, that we have a separate critical care EPR. So we manage 2 prescribing systems for our inpatients. And that itself would be complicated enough. However, it's even wider than that. We manage a whole host of local innovations that support our clinical and operational practice. So we have a number of in-house developments that we refer to as our portal. We've got an ePMA portal that does all sorts of wonderful functionality. Ben's going to outline a couple of the neat pieces that we've developed around that when we come to him. We have a lot of automation in place within pharmacy. We have systems managing, you know, some of our sort of business processes, our annual leave, our loo time, how we gather information for FOIs, how we book our hot desks. We've got a variety of different systems that we're using for that, and they're all systems that are in-house developed and managed. So we've got a responsibility not only from a clinical safety angle, but from a safe and effective systems provision to keep these systems running. Now, sitting alongside that further, we've got additional systems that we need to either have an awareness of or, again, directly manage. So we have a number of systems there. We somehow, because we are, I guess, digitally aware and responsible for the digital function of our department, we manage our file structures. We look after how we use SharePoint, how we use Teams, how we communicate with each other. And alongside some of these more specialist systems that are managed at department level, I guess it builds to that picture that we are not just ePMA, and that we have a whole host of systems and considerations that we need to take into account. So bringing that all together is how we present our digital pharmacy universe to anybody who's interested in what we get up to. And it just, I guess, hopefully explains that we are wider than the ePMA system, and that actually there's a whole set of different skills needed to be able to understand this, talk to the level of integration, the data and the automation that we're doing within our team. So I hope that was a bit of a good introduction as to the complexity of what we're trying to manage. You know, we're covering around about 2,000 inpatient beds across our systems. and we've got the complexity now that we've got the group approach across Liverpool, that we're trying to figure out how that's going to sit going forward. I will hand over now to Ben, who's going to introduce himself and walk through some of our innovations that we've developed in-house. Thanks, Ben.
Thanks, Sarah. Yeah, so I'm Ben Logan. I'm a lead EPMA pharmacist here at Luft, and I'm going to take the opportunity to just talk about a few of our innovations in our EPMA portal that Sarah briefly described, and with a bit of a link to medicine safety. So first of all, just to outline, one of the challenges we had last year is that we wanted to repeat the EQUIP study. So I'm sure a lot of people are familiar with the EQUIP study, but it was a study carried out in 2009 that was looking at prescribing errors. So that was carried out across 19 hospitals and looked at around 124,000 medications just to check what's our error rate like in acute trusts. And a lot of information came out of that, such as errors, severity of errors, what types of drugs were causing the most errors, and what sort of staff groups were producing prescribing errors. So we wanted to repeat this to support a bit of work within the trust. A lot of things have moved on since 2009. A lot more trusts are now no longer paper-based as well. We've got a lot more different types of prescribers, more NMPs, so the landscape's changed a lot. So next slide, please, Sarah. So as I said, we wanted to repeat the audit. We were planning to repeat it across all of our sites. So that's the Aintree, Broad Green, Royal and Walton. So we're about 2,500 beds, and we have about 100 pharmacists as well. So it's a big ask. We'd done it in the past before my time, but I believe it was a very laborious task. As you can imagine, transcribing it was all paper-based. So pharmacists went out, audited the patients, filled in little sheets. They were then collected centrally, and that was all analysed. So we decided against doing that, and we wanted to look at some sort of digital opportunities to do the audit. So one of the first things we looked at was SharePoint forms, which would have been ideal, but we couldn't really get it to work without it being quite a big manual data entry task. So I've put a little example there at the bottom. You'd still be typing in patients' details, drugs, and what have you. So we decided to link it to what's known as our ePMA portal. So it's an in-house built system, which is essentially just a website which has been built over a number of years. The benefit of it is it's able to pull information from a lot of different systems, including our ePMA system. So it sort of acts as a bridge between our ePMA system and our stock control system, allowing us to do a bit of functionality that's not in our system. So things like patient acuity scoring, some medicines ordering stuff as well, a lot of different reporting solutions, and it all powers our sort of stock control and dispensing processes. So it actually links to some RPA processes as well for us to be able to label automatically. Next slide, please. So here's a little snapshot of what that looks like. So this is our pharmacy acuity dashboard. So it allows pharmacists to monitor their inpatient ward. It pulls live data from the system. It provides information that I'm sure most people have at their trusts in various formats. So medicines reconciliation status, whether a patient's had a new medication, and whether they've got any critical medications, amongst a lot of other different things. So this is used predominantly by pharmacists most of the day when they're out there doing their inpatient wards. So it felt like the right place to put an audit tool if we were going to be using it for the day. So this was the tool that was developed, and as you can see, it's a pre-populated audit form. So it actually was pulling for each patient. When you clicked on them, it was pulling their live data. So it had all of the patient's demographic data that we needed to audit. It had all the medication details as well. And what the idea was that we would take that and we put each drug on a line with a quick audit form. Next slide, please. So for each line, if there was an error with a prescription, or that if we had made a clinical intervention against that prescription, the pharmacist would be able to click each option. So try to make it as easy as possible to use. So it was a minimum of, I think, 4 buttons they would need to submit for each error. So that was a mixture of drop-down groups, whether they were able to select things such as where did the error occur, was it an admission or a discharge prescription, what was the error type. So that allowed them to put several different types of error in there. So was it incorrect dose, incorrect frequency, with a mixture of several different things. And this allowed us to not only make the form quick and easy to use to try and get better uptake of the audit, but also streamline some of the data, make data very consistent, easier to analyze at the other end. Next slide, please. In addition to this, we're not fully EPMA for all of our prescribing, so we've just gone live with crit care, as Sarah said, but we've also got some paper-based prescribing as well, particularly in outpatients, particularly for some of our infusions. So we did allow people to be able to free type medication. So there's an example of that on the screen there. We also collected a little bit more advice. So you could have seen on the bottom of that slide that if we're providing TDM advice to the ward as well, we collected that as well. So the idea is to get an overall picture of our clinical service. So results, I'm not going to delve into the actual error results, or kind of going to focus on the success of the audit. So in addition to the actual form, we were able to display the results in real time via a live dashboard. So put a little screenshot at the bottom there. So we're able to see who was submitting forms, how many we were up to, so how many prescriptions have been reviewed. So this audit was carried out in 1 working day. And in that day, we were able to capture data for almost 1,200 patients. And those were all patients with at least 1 new medication prescribed that day. In total, that was 10,000 almost prescriptions that were reviewed in 1 day. Of those, we saw an error rate of about 16%. So that was 1,599, and we undertook about 224 proactive clinical interventions as well. So one of the key things for me, and when I designed this, we wanted to make it as easy as possible. So we captured how long each pharmacist was taking to record an error, and on average that was about 38 seconds per patient. So it seemed to work well. So the outcomes, so the data supported a lot of different things. It highlighted a lot of key areas for us where we could optimize the system. And it also provided weight to some known issues. So we were able to look at what drugs are most likely affected. We weren't surprised by some of them, but it's been able to add a little bit of weight. We've been able to quote it when making changes or arguing for changes. So that's been really positive. We've also been able to provide support for clinical team business cases. So we've been able to show, so that we do this many interventions on a day. We have a smaller team at the weekend, maybe we need some funding to increase that type of thing. So that's been really positive. There were a few limitations. So there's lots of development time. So we could have gone down the SharePoint route. That could have been done in an afternoon. That would have been brilliant. But this took weeks of work, if I'm honest. The data capture was fast and really simple, so it's great for our clinical colleagues. It was really easy to report some of the headlines like I had on the last slide of total number of errors, but there was a lot of scrutiny that still had to go into it. So because we collected so much data, there were things like this error severity in particular, potentially lethal class is quite subject to someone's opinion really. So they were all clinically verified by someone independent. So that took a lot of time as well. And the fact that I allowed manual data entry as well, that required a lot of cleaning because there were a lot of different misspellings of drugs and what have you, and different comments as well. So the manual effort that's required to do an audit on this scale is often a big barrier to data collection. So this project sort of demonstrated the power of integrating electronic systems into within audit tools. It really helped us to be able to sort of collate data en masse in a very quick period of time. So the tool was very successful for this audit, but it's also actually been subsequently used for a lot of smaller audits to support things like we had recently did a few ITU step down audits to support our crit care go live. So that's been used a few times since. And we've also used the same methodology for some other parts of our department as well. So a big one is using sort of similar thing, pulling through antibiotic data to be able to automate part of our point prevalence auditing for antimicrobials as well. So thank you very much. That's me done. I'll pass over to Leah.
Hi everyone, so I'm Leah Baker. I'm the Medicine Safety Officer here at Liverpool University Hospitals, and I have proud to say that I've got a really good working relationship with Ben and more recently Sarah, and now kindly with Emma. So just to pick up on what Ben has said from our EQUIP study, no surprises that anticoagulants were quite high up in terms of our drug causes of prescription errors, and that has prompted us to think around those errors which we see, the volume which is identified in and QIP, we don't see any of them reported in our, or nowhere near that volume reported in our incident system. And also to turn our attention to how can we potentially turn on this type of reporting to get a real sense of what degree of risk and error have we got in our organisation on a given day. So we've touched on it there for antimicrobials. There's definitely scope and consideration here when I talk through our risk of dual anticoagulant errors as to whether we would periodically turn that on to get a real sense of what is out there and what is still driving our ongoing errors. So as I've said, I'm going to touch on dual anticoagulation. So by that I mean where a patient is unintentionally prescribed two anticoagulant medicines, not those occasions where potentially a much smaller number of patients would require double anticoagulation for a bridging type period. So I'm going to focus on using the benefits of, sorry, if we can just jump back, Sarah, if we can focus on using the benefits of reporting out of our electronic systems to prevent the next predictable error. Conscious that some of these terms are probably quite triggering, and have they actually, are they worded correctly? Compensating for prescription error and alert for fatigue by intervening potentially earlier than a human can, and waiting for the system fix to catch up. So next slide, please, Sarah. So we will see that we have been working on this for quite a while. Sarah has alluded to, we upgraded our WellSky system into CareFlow earlier last week, and that has now brought what hopefully will be an optimized system to drive down some of these incidents. So I've touched on unintentional prescriptions of two anticoagulants, and the key types of incidents which we see is a patient admitted on an anticoagulant that's temporarily suspended on admission. They are then prescribed thromboprophylaxis in the form of low molecular weight heparin injection. The decision is made then that the anticoagulant can be safely resumed, and that is done then without discontinuing the thromboprophylaxis. And on this occasion, our system is not triggering a duplicate therapy warning or an interaction warning, or what we would refer to as no conflict log visible for the prescriber. We then have the instance where a VTE assessment and subsequent thromboprophylaxis is prescribed on admission. That is continued, but at some point during that patient's stay, they have a new indication for an anticoagulant that is prescribed, but the requirement to then discontinue their low molecular weight heparin prophylaxis is overlooked, and then that's subsequently not discontinued. And in that occasion, a conflict log would be visible to the prescriber, but that may or may not be alongside multiple other conflicts on that particular prescription interaction. We've also got VTE assessment and thromboprophylaxis prescribed on admission, and there's a failure to identify that this patient is already on an anticoagulant. And depending on the sequence of those events, the conflict log may or may not be visible, depending on whether that anticoagulant has already been prescribed. So conflict log, I've mentioned a lot. What I'm meaning by that is decision support, triggering a prescriber to have some information around the fact that this new medication may have an interaction, may have an allergy flag, or may have a duplicate therapy. So prescribers will often quote to us, they receive multiple alerts. There will be variability in the priority status, and that may or may not be presented to them in an easy to interpret and view format. And of particular note, the conflict log warnings were not previously, until the start of last week, visible when a suspended medication was resumed. So often it wouldn't be the initial prescriber who may have seen that the patient had conflicts who was resuming that medication, and they will be blindly resuming the medication with or without the knowledge that they needed to review the additional prescription due to a conflict. If they were aware they needed to review the full prescription, which should be commonplace in all prescribing episodes, the actual view of the prescription screen and the oversight of a full list of a patient's prescribed medicines or medicines to be charted can be challenging for our prescribers. So they can choose to order their prescription screens from an alphabetical list, from a drug group status, from a start date status. That may on occasions require multiple scrolls of a screen, and depending on what double anticoagulants we're looking at, they may or may not be presented next to each other. Then we've got the issue of what do you choose for your default settings with respect to your anticoagulant medications in your systems if you do choose to have defaults. And there are lots of benefits of defaulting systems to what are considered the safe doses, if you can, the safe frequencies, the correct dose. So on occasions, we predominantly have got our oral anticoagulants defaulted to the morning, so traditionally 8 o'clock, and we have currently got our low molecular weight heparin prescriptions defaulted to 9 a.m, 9 p.m, or to both if it's a twice daily prescription. And notably, they span often different nursing shifts. So our nursing staff, if we were treating them as a potential opportunity to intervene once an error has happened, are less able to identify that there might well be a duplicate therapy. And then further thinking in terms of the timing that prescribers are completing follow-up jobs from ward rounds, cleaning up prescribing tasks at the end of the day, acting on additional requests from pharmacists, that tends to be later on when they are due to be finishing their shift, which then prompts often, depending on what your clinical pharmacy service hours are in your hospitals, into an out-of-hours scenario, which then limits significantly the opportunity to intervene, well, identify firstly, and then intervene before the next scheduled dose. If we can move on to the next slide, please, Sarah. So this is just showing one example of what our current WellSky care flow will show from an interaction therapy warning in terms of a high severity due to an increased bleeding risk. It will ask for an acknowledgement, but it won't necessarily present clear rationale as to when the last dose was, when the next dose is, and support the prescriber to make the decisions. Next slide, please, Sarah. I think we've got 2 clicks to go. And until recently, we haven't had that even visible at the point of resuming the prescription. And if we can move on to the next slide. Okay, so what did we do about this? We were seeing frequently reported errors. We were commonly feeding back to prescribers. We had commonality in the feedback of, well, I didn't know they were still on the anticoagulant. I struggled to look through the prescription to identify it. I was just doing a job that somebody asked me to do. I'm really sorry. So we had quite a lot of discussion between myself, the safety team, and digital medicines team, and our anticoagulant pharmacists, and set out to develop a report which would try and identify this error as close to the time it has happened and give us a potential to intervene. That did have lots of discussion and consideration about who would actually access this report, who would implement the report. Could we do this weekdays only, or would we do this on the weekends? And it was not without significant discussion. And of note, we did implement this weekdays only to start with, rightly or wrongly, by the medicine safety team, so a much smaller group of people, before we ultimately rolled that out across the weekend, expanded that into our weekend clinical pharmacy team, and to date, as to currently doing it right across our clinical pharmacists. So it's currently not done by the medicine safety team unless they happen to be the member of staff on the rota from a clinical perspective. We absolutely have got record keeping, and we are ongoingly monitoring our compliance with how we are acting and implementing the report review, and then what actually the report is triggering in terms of incidents. And we have tried, as we've gone along, to optimize what that report is doing for us. So we had in the early days, and honestly still quite a few missed checks acknowledged. When we actually review that, the checks often haven't been missed, but the documentation of the check has been. And our checkbox of acknowledging the check has been completed is at the top of the screen, but you have to scroll down all of your patients to have completed your check. So that is something that we are continuing to look to optimize. We have added in an opportunity to facilitate incident reporting. We have had lots of discussion over, should all of these be incident reported? If we know that there's a risk and we know we are acting on it, should we add in an extra process step? So we have got a prompt for Datix reporting. We have got an option for the person completing the report to trigger the fact that there was an incident on review to the medicine safety team to then put into our central Datix reporting system. We have got an increase in our incidents being reported because we have got a trigger report in place, and managing some of the additional conversation that creates outside of the department is something that we do have to ongoingly navigate. We are actively in discussions around the timing of the report at the moment, and are we running the report at a time that is appropriate for our clinical pharmacy service, or are we running the report at a time where it is more commonplace that the prescription error will happen, and with an opportunity to intervene before the next dose is scheduled to be administered. In terms of post-implementation, so we are post-implementing a report, we are continuing to do that report. What does success look like, and how long will we continue it for? Potentially until enhanced decision support drives down some of these errors. Next slide, please, Sarah. So I'm just going to jump through these. These are the current process steps in our SOP. It gives you a quick visual of what it looks like in our report, and noteworthy that we have got it shown here for 3 of our hospital sites, and we also run this for our Walton Centre site as well. Last part of that box shows that we remove the dual anticoagulants where one of the prescriptions is suspended. We have still got a lot of active prescriptions where there is one active drug and there is a suspended drug. There has been some query about would we also review them just in case it's suspended when we're not here. The volume of prescriptions on that report would mean that we wouldn't be able to complete the report. So we actually review the active dual anticoagulants and not the suspended ones. You probably wouldn't have caught it when Ben showed his slides before. You might have spotted a little bridge for the eagle eyes. That bridge is shown within our standard clinical pharmacy portal to highlight to individual ward pharmacists that this patient has got 2 anticoagulant prescriptions in place. If we can move next slide, please, Sarah. Okay, this is a view of what the report looks like, and of note you'll see that mid-screen where we've got the greens for Aintree and the Royal, that is where we're acknowledging that we have done our report. We've also got some visibility of what the patient's INR is, if they have got an INR, and Ben alluded to pulling in into our in-house portal information from other systems, and that's our results reporting system. And we've got the prompts on the right-hand side for the prescription error to be reported, and the user can actually click on that and use that to do a standardized automated trigger email to the medicine safety team, which will be linked to the particular patient in question and the date and time of the report. And next slide, please. Okay, so did we know about this in advance, and why didn't we have the report set up when we knew about the error? So the interaction check on resuming suspended medicines is not unique to anticoagulants. It's just particularly commonplace because there is commonplace practice where we will suspend, resume, or initiate a new anticoagulant prescription in hospital. Last bullet on there shows that we have had an improvement plan for VTE assessment and prescribing, which may or may not be driving some of the increased frequency of thromboprophylaxis being added to patients who are already on an anticoagulant. We didn't have much else we could do with the resource that we had at the time that this hazard was on our hazard log back in 2020. And we have only as of last week, being able to reduce down that hazard score. It's actively going to be reviewed because we have said that we are hopeful that we will drive down, obviously, the incidents where the anticoagulant has been resumed, but lots of these incidents are not linked to resume and are also just linked to a new prescription where that conflict log is clearly visible, and we have to then think about what can, if anything, we do around alert prioritization, and we've got extreme limitations, if any, ability to modify that within our system, and know and accept and educate and mitigate around alert fatigue. We've absolutely got to embed prescription review on our ward rounds and think about actually how easy is it for staff to view multiple screens and multiple systems at any one time. We move on to the next slide for my sum up. And I just wanted to touch base. I'm not going to go through all of these reports, but this is sort of some examples of other reports that we use for safety benefits, utilising either a report directly out of our electronic prescribing system or utilising a sort of a integration with our portal, and some other things that are under consideration, and you'll note that quite a lot of them relate to high-risk drugs. And of particular note, linking back to what Ben's alluded to with repeating a quip, there are other potential sort of reviews, reports, audits that we'd like to do around early recognition of error. So those prescribers who discontinue their own prescription quite quickly after they've done the prescription, drugs discontinued by somebody else as prescribed in error, how can we actually more proactively know our risks and do something about our risks rather than potentially rely on much later downstream clinical pharmacy services picking up on it? And can you do that without actually additional resource allocated to be able to review, generate, act on the report? And the staff acting on the report, should they be able to be a facilitator, or should they be able to correct the error, which comes into conversation of whether you would ideally have these reports done by a non-medical prescribing pharmacist? And that is it for me, which gives small opportunity for questions, and I'll hand back over to the central team.
Thank you very much, Leah. Some really interesting stuff there. There are some questions in the chat which I don't know you might want to answer in the chat rather than me putting them to the speakers. Some people wanting to connect and people asking about the actual makeup of your team. One thing I do is there's amazing work that you have done in Liverpool, but you have a big digital team and you have a big med safety team. And from now, you know, I'm working in an organisation with 1 med safety pharmacist and 2 in a digital team. These things are, you are able to do them because you've got the capacity, and it's then about, you know, we all need to learn how to be clever with the data we've got to try and build these business cases when we know that at the moment it's very, very difficult to get the money. But yeah, you've shared some really interesting things. I had a question, Leah, just about the report. So you've got all of those reports. Generally, who is it that's going through them? So you said about now that the anti-coag one has gone over to the clinical team. What about all your other reports?
So there is a combination at the moment. Some of the reports, potentially we could throw them up on screen, which are predominantly linked to penicillamine or drug C notes. So the ability of the electronic system to almost do things that you wouldn't want it to do. They are managed predominantly by the digital team during the week, but we have then got that managed by the dispensary team of a weekend. In terms of the valproate and methotrexate and midazolam reports, they are by the medicine safety team. They're much less frequent triggered reports, but with respect to the gentamicin and anticoagulants, they are absolutely embedded in our clinical pharmacy teams on rotas now. What we've done with both of those reports is have them owned by the medicine safety team for quite a significant period of time while we optimize and learn how we would use them, but we would then have to shift them into business as usual. And the conversations which we're just having with some of those reports done by the safety team at the moment is we probably can't take a new one on. You'll see clozapine down there, steroids down there. We can't take a new one on without considering potentially we've reached the point of mitigation of some of the others and not doing the report, if that helps answer the question.
It does. And from, you know, looking at a report, when I've worked in organisations with reports before, some of them just haven't been utilised, but also you can sometimes feel that it pushes people to do things as a task rather than looking at the patient holistically. Have you found any unintended consequences like that?
Not that we've become aware of. Essentially, these reports, the report is done by somebody, but the intention is that they are en masse, the transactions to link back in with the ward pharmacist and the clinical team to actually review and correct them prescriptions, including at weekends. So that often it's a prompted conversation with the clinical team and an instant report submitted so that all of the behind the scenes things that have to happen with them are done.
Thanks, Leah. Just trying to look through the questions. I can just see Bianca's written, given the recent HSSIB report, reporting like this around suspensions going on for longer than a few hours a day seems the next step. Have you got any plans? Then this seems to create a lot of new work. And how have you decided which interventions need this level of work?
So I don't think I quite get the suspension. Is that as to whether you would have a medicine which is actively suspended for a significant period of time? So I think if there is a question on suspending medicines and whether that's the appropriate and correct and safe practice, we have previously seen risk on the contrary, where if you don't suspend an anticoagulant that a patient was on when they were admitted to hospital, then there is no active prompt for that to be resumed. And we have historically had instances where people will then be discharged without that anticoagulant being resumed. In terms of how we prioritise, locally, we have had significant harm events with gentamicin. We have got high frequency events and some significant harm events with anticoagulants, and we'll know anticoagulants, not necessarily for this reason, are high up on the national priorities. So it's local intelligence, high risk nature of the medicine. PSEF doesn't lend us to think about the harm status, but this is often harm and high frequency and need to mitigate something that currently some of our electronic systems can't do.
Thanks, Leah. I think we're hitting 2 o'clock. So just to say thank you so much to all of our speakers and all of the engagement, chat and questions. The slides do become available, don't they, Amna?
Yes, so the slides...
I'll just say thank you and I'll hand back over. But yeah, thanks to everyone for joining us today, and I'll hand over to Amna.
Thanks, Emma, and thank you to Brian, Leah, Sarah, Ben, and Leah about sharing their presentations today. And in terms of the slides, they are available. They'll be available after today on NHS Futures, as well as a recording of the webinar today. And just like to echo everyone's thanks for their engagement today. Our next masterclass is on the 16th of July. If you scan the QR code, it will take you to the registration page. And if you do have any ideas for future topics, please do email Rosina. And I hope you have a great rest of the day. Thank you for joining us today. It was great to see all of you here, and I'll see you in July.